All right, welcome. Thank you everyone for joining us in this episode. Shaun Brewster and Bodine Ledden here with you again today. Today's topic is on Greater Trochanteric Pain Syndrome. We recently ran a webinar on this that Bo presented. A hugely popular webinar. In fact, it was the about 5 times more people than we've ever had on a webinar, which tells you that this was a hot topic for a lot of people. Bo, I thought we might just explore this topic today. I'll ask you a few questions and maybe you can give the audience a bit more context around this presentation that actually covers a lot of different things and a lot of different pain presentations that people might experience day to day in the hip. How's that
Yeah,
sound?
and it's such a common presentation that we see, but it is often misunderstood, misdiagnosed, and mismanaged. So I think really understanding what it is, how to assess for it, and how to manage it is such an important thing that clinicians should really know as far as integrating treatment and getting the best outcomes for their patients.
Yeah, fantastic. So let's first of all start with a bit of a definition. What is Greater Trochanteric Pain Syndrome, or GTPS?
Yeah, so GTPS it's essentially an umbrella of conditions around the lateral hip, and that includes things such as trochanteric bursitis, gluteus medius and minimus tears and tendinopathies. It can include external snapping hip syndrome. It can include complete ruptures of the gluteus tendon, gluteus medius and minimus tendons. Um, so that's sort of mainly what it'll cover, as well as a proximal ITB syndrome as well. But they'll all fit under that umbrella of greater trochanteric pain syndrome.
We see a lot of these syndromes now, right, which is really just a collection of different types of presentations in an area. It does, I think, free us a little bit in our diagnosis to sort of say, okay, there's pain in this region, and not sort of put the blinkers on us and go, well, it's the bursa or it's the tendon or whatever. We can focus in on the region and do then a better assessment. Is that fair to say?
Yeah, exactly. I mean, and sometimes like a syndrome, it can lead to a little bit of, I guess, misunderstanding about where to direct the treatment towards. And when we think about some of those things that may fall in that umbrella, such as a bursitis, so itis meaning inflammation versus a tendinopathy, and how we would typically manage those different conditions. And when a patient has an inflammatory condition, the typical approach is a passive approach that would include things such as rest, ice, and maybe stretching. Whereas when we look at tendinopathy, and that's where it really is important to distinguish some of these conditions, because we know that tendinopathy is typically a load-based presentation. And so we've got to understand how we can manage load and incorporate load into the overall management, whether that's an increase to build capacity or modifying or modulating how much load is going through that region. And so when we look at GTPS, the primary driver there is most likely going to be a gluteal tendinopathy. And this is the most prevalent lower limb tendinopathy. And so that's why they can be very tricky to manage, is because often they are misdiagnosed and mislabeled as a bursitis. And again, that can lead to that sort of misdirection, mismanagement. Because if we look at how we would manage a tendinopathy, typically it's going to result in exercise loading, heavy resistance-based exercise, and progressions back towards restoring the overall capacity of the tendon.
Yeah, right. And I think when you say greater trochanteric pain syndrome, I think if you didn't know what that was, I think a lot of people might jump to this conclusion or the idea of bursitis that you mentioned before. And so maybe it'd be good if we differentiate, bursitis from tendinopathy, obviously two completely different mechanisms and pathologies. But let's talk a little bit more about the bursitis for a moment so we can clear that up.
Yeah, and it's a really good one to understand, like what the bursa's role is for one. So its role is to absorb and distribute load over a greater surface at the enthesis. And so when we talk about the greater trochanteric, sorry, the gluteal tendon, so there is a pretty short tendon, but they'll attach onto different facets of the greater trochanter. So for the gluteus medius, it'll be onto the lateral facet, and then we've got the gluteus minimus on the anterior facet. And so what's interesting is we've also got the ITB that'll sit over the top of those tendons, so over the lateral aspect of that hip. And so when we talk about greater trochanteric pain syndrome, it's essentially pain around that greater trochanter. But if it's tender and painful over that area, people often will jump to the conclusion, well, it must be the bursa that's irritated and inflamed and sensitized. And while that can happen, the incidence of primary bursitis is very low. So primary bursitis meaning that the bursitis is the only pathological entity around that area that can be linked with that pain experience. And so there are numerous papers that'll suggest that the incidence of this primary bursitis is very small, and that's why we've got to look beyond that bursitis. And yeah, it can coexist with tendinopathy. However, it's often secondary. And so when we understand that it's often going to be secondary to these tendinopathic changes, well, we've got to address the treatment at the tendon and not necessarily the bursa. Because we see this a lot where, well, the bursa is inflamed and sensitized. What can we do? Well, let's get a corticosteroid injection for the bursa to settle that down. Well, I mean, we can talk a little bit more about that later on, but we know that the influence that can have that can negatively impact tendon health. And so while it may have some short-term benefits, the influence at long-term follow-ups is often worse off than conservative management. So yes, bursitis can certainly play a role in elevated levels of sensitivity. There's been studies that have demonstrated elevated levels of substance P in the bursa. And so obviously that can certainly sensitize that area. But again, questioning, is that the primary driver here? And so we should be looking at addressing the primary here, which is often going to be the tendon. But, we will often see on imaging bursal thickening. And so bursal thickening is not necessarily a bad thing. It's a normal adaptive response to load. We see this all over the body. We see it in the shoulder, in the subacromial bursa. And so because of its role, its function to distribute loads over a greater area at the enthesis at the greater trochanter, well, if someone is increasing their volume of training, their intensity, whatever that may be, well, that bursal thickening will be a normal adaptive response to loading. But it's when there's sort of that increase in unaccustomed load or overload or even underload, and then the person goes about, walking up a hill, well, that could be enough to sort of cause some sensitization, irritation to the tendon, and there's various different stages that can go through. But it doesn't necessarily mean that it's a bursa problem. So yeah, I think understanding the role of the bursa and its importance, and same goes for the role of the tendon, which the tendon's role is to store and release energy. And so that's sort of important when we see that there can be these pathological changes that occur to the tendon and changes to the tendon matrix that impairs its ability to store and release energy.
That's right. And when we're talking about tendons, I guess that's really the primary consideration with a lot of these GTPS presentations, right? It's gluteal tendinopathy, as you mentioned before. And so typically when we're talking about tendinopathies, it's a load tolerance issue, isn't it? Like you're talking about the bursa also has load tolerance issues based on, the amount of work or load that's been placed through it over time. That's definitely the case with tendons. So what's the typical mechanism involved in developing a gluteal tendinopathy, maybe compared to some other regions of the body?
Yeah, it's a good question. And so when we think about, as I said, sort of the anatomy around that area where we'll have a pretty short tendon, but it'll attach over the lateral aspect or the anterior aspect of the greater trochanter. And so what we often see is there'll be changes to the tendon matrix on the undersurface. Now, there is a compressive zone on the undersurface of the tendon, which is sort of the enthesis organ. And so in that compressive zone, there will be more chondritic changes or more cartilage-like changes. And the role of those cartilage-like changes is to actually absorb load. So these chondrocytes, they'll sort of attract more water around that area. So it behaves more like cartilage. And so that's normal to have a compressive zone there. But what can happen if there is too much compression over around that area, and that could be from the undersurface with the compression against the greater trochanter, but also where the ITB will sit over the top, that can increase the amount of compressive force. So we've got compression from the ITB, thick fibrous band, and the underlying bony tissue. So it sort of creates a little bit like I refer to it as a tendon sandwich. And so I guess the issue with that is over time, we have increased amounts of these large proteoglycans. So within the extracellular matrix, that we see these large proteoglycans, and essentially what they do is they bind onto water. And when they bind onto water, they sort of have more of a protective response of the collagen fibers. And so because they're now having a protective response as sort of a cushioning effect, that can disrupt the parallel arrangement of the collagen fibers. Now, when we look at collagen fibers in a tendon, they are typically in parallel arrangement. And so they're very, very strong, very tensile, able to withstand a lot of high tensile force. Okay. And so if that parallel arrangement starts to be disturbed by upregulation of these larger proteoglycans, there can be disorganization of this tendon matrix because it's now more able to withstand compressive load, but that may impair its ability to withstand the tensile load. Okay, and so there are various sort of reasons for this. It could be that the person is spending a lot of time in compression. So, for example, sitting in low chairs. It could be that they spend a lot of time sitting with their legs crossed. When they stand up, they may hang out on one hip. They may have some instability through that hip. So when they walk or when they run, they sort of move into that Trendelenburg gait. And all of this is doing, it's increasing the amount of adduction. So the greater the range of adduction, that can obviously increase the compressive load over the gluteal tendons at the greater trochanter. And so when you think about that, so if we start walking, there's a larger amount of I guess, ground reaction force. And then as we start to run, again, that can increase. If there's instability through that hip and they start to cross the midline when they walk or when they run, or we sort of see that contralateral hip drop, again, this is increasing the amount of adduction force and compressive load over the greater trochanter. So the tendon's response to that will be to increase the amount of large proteoglycans. And so those large proteoglycans will be binding water as a protective response to that compressive load. And so you can see over a longer period of time, then this cumulative nature of compression can impair the overall function and structure of the gluteal tendons.
Isn't that the human body an amazing thing? Like we can use inappropriate or ineffective gait, and as a result, the tendon can modify itself to withstand that compressive load because that's what we're applying to it. But then, of course, if we correct the gait and use the tendon appropriately, then there's a cost-benefit ratio to those adaptations. So the body is amazing that it'll adapt to just about any situation we put it in, but there's always a cost-benefit ratio to consider. And it comes down to tendon health in this case, of course.
Yeah, exactly. And when we look at the tendon cells, you've got the tenocytes, and these are those mature tendon cells, and their role is to synthesize collagen. Okay, and so that's why when we think about, and what we'll talk about later with I guess management, because those tenocytes are so responsive to load, if we apply the appropriate load and allow adequate time for adaptation and recovery, well, the tendon health will improve and we'll have increased synthesis of collagen. However, if there is underload, the same thing can occur. There will be less synthesis of these collagen fibers and the tendon health can decrease. So you think about that from a period of, a gradual progressive increase in load versus complete rest and then going out for a 15K walk or run without doing any sort of training for that. Someone who may have various other risk factors may be more vulnerable or at a higher risk of developing a gluteal tendinopathy because they've gone from being completely unaccustomed to a huge amount of load. So the tendon's response to that will be, okay, protect. We need more water binding molecules around this area to sort of create more of I guess, cushioning or protection around this area. So, I mean, short term, that can be modified pretty easily. We just modify load, but if this is sort of continuing to happen without appropriate load modification, then we can see these longer term changes to the tendon matrix.
Sure. Now, you mentioned a little while ago that GTPS is probably the most common lower limb tendinopathy that we see clinically. I think a lot of clinicians would be probably surprised to hear that, thinking that maybe it's the Achilles or patella tendinopathy that we're seeing, particularly in the active population. But as I cast mine back through years of clinical experience, I've seen so many lateral hip presentations that may have masqueraded as something else at the time. So if we look at clinical features of a GTPS, what are the key things we're looking for?
Yeah, perfect. So, I mean, when we look at it typically, and this will come into it when we think about the assessment and how we can sort of narrow this down to ensure that we are on the right track. But a patient will often present with tenderness and pain over the lateral hip. So it will be pain to pressure around that area. They'll often describe that it's worse with single leg activities, and it could be that they would say it's worse walking up stairs or walking up hills. If they're doing a lot of running, so this is those high amounts of stretch shortening cycles. It could be that they're just describing that it's really uncomfortable when they're sitting at work, and that pain is around the lateral aspect of the hip, and it may refer into the lateral thigh and even into the leg. So you'll often see that in more severe cases where there will be a larger referral zone for this one. But they'll often say that it can disrupt their sleep. So it can be very uncomfortable laying on their side, either on the symptomatic side or on the asymptomatic side, with the painful hip sort of flexed to 90 degrees with that hip adducted. So that can often be some pretty common features that we'll see. Yeah, I think that's about it. So yeah, usually it's going to be worse in sitting cross-legged, and that could be with the ankles crossed, knees crossed, ankle over the top of the knee, a number of different variations there. They can all increase compressive load to the gluteal tendons.
Yeah, right. And so I guess you'd say that most of the observable clinical features, the pain in certain positions, give us a really good clue as to what's going on. What about then further more specific assessment? What about maybe orthopedic or other types of assessment that you could do?
Yeah, for sure. So I think firstly, it's good to start with their history. I mean, the highest risk factor in most people, I guess, highest prevalence is going to be females between the age of 40 to 60 years of age, peri and postmenopausal women. It certainly can happen in males as well, and also in younger populations, but it's about a ratio of 1 to 6 males to females. So far more common in females. And so in those populations, you're also keeping an eye out for any changes in activity. So if they've had a change in their exercise intensity, their frequency, they may have just got a dog and they've started going for longer walks with the dog. They may have changed jobs and they're starting to walk upstairs, or they've got to, catch the bus and now walking to the bus, whatever that may be. There's usually going to be some change in their exercise frequency, intensity, time, type, duration, whatever that may be. And obviously medication use, age, genetics, smoking status, all of these risk factors certainly can play a big role. But when we look at this clinically, when a patient comes in and they've presented with symptoms in the lateral hip, we've taken a thorough history. a useful area to start is just with some functional performance tests. Now, these diagnostically aren't the best, but it can give us a bit of an idea of how well they're functioning. And so that could start with things like a double leg squat. We could get them to then increase the amount of load through there by going into a split squat. And so what you're looking for here is, I guess, just can they perform the movement? Does it exacerbate their symptoms? Is there significant lateral shift through the hips, or are they sort of dropping into that knee valgus? And so we can get them to do several reps of that. Usually it's not adequate just to do one rep of each. So get them to repeat this several times. And then we could start to increase the amount of load. So we could get them to stand on one leg, which is a useful special test, a single leg stance for 30 seconds. So what we're looking at here is pain provocation within 30 seconds in the lateral hip. Okay, so we're not really looking at a Trendelenburg test where we're looking for that pelvic drop. That can be a functional test that you do. Again, not very specific diagnostically. But, if a patient is describing their symptoms are worse with running, for example, then you might get them to do repeated hops on one leg to see if we can reproduce those symptoms. Or it might be that you're getting them to do repeated single leg squats. So you're looking to see, again, how well they can perform it, but if this reproduces those familiar symptoms. So that's where I'd probably start as far as functional tests. From there, obviously, palpation is one of those tests that has a very high sensitivity but low specificity. So palpation around the greater trochanter is useful because if it's not painful, it can be useful to rule out gluteal tendinopathy or GTPS. So pain on palpation around the greater trochanter is an important indicator in combination with other tests such as the single leg stance. So if they've got a positive for pain on palpation around the greater trochanter plus a positive single leg stance, those two tests in combination can be useful for ruling in gluteal tendinopathy because a single leg stance has a very high specificity. So meaning that if this test is positive, it's more likely that that is an accurate diagnosis for their lateral hip pain. So they're two good tests to start with. I think going from there, if we get our patient onto the table and we want to sort of narrow this down a little bit more and confirm our suspicions, rule in or rule out other sources of hip pain or lower back pain, we can then move into an AD test. So it's essentially like a modified Ober's test. So the patient's in a side-lying position. We drop their top leg or the symptomatic leg off the side of the table. And we're trying to add some overpressure into adduction because, again, we spoke about the mechanisms here of increased compressive load. So if we get a response there, then that's obviously a positive test. But to improve the specificity of that test, we can ask our patient to abduct the hip, so against our resistance. So we're getting them to push up while they're already in an adducted position. So that's the combination of tensile load and compressive load. And Alison Grimaldi's got a great paper on these tests as well. So then we can go into a fader test. So this is the patient supine, laying on their back. We take their hip into hip flexion, hip adduction, and hip external rotation. So it's very similar to a glute stretch. And this is why when we look at these pain provocation tests, that glute stretching may not be the most appropriate. And so we're taking them into that compressed position and seeing if that reproduces their symptoms. To then follow on from there, we can ask them to resist against us. So getting them to maximally resist. And again, we're looking for the reproduction of those familiar symptoms, and that will increase the sensitivity and specificity of the test. And then there's also a Faber test. This is a pretty common one that we see used for hip pain, groin pain, lateral hip pain, could be for low back pain and SIJ pain. So it's not the most specific and not the most sensitive test. But when we do a Faber test, we're sort of looking for the differentiation between hip and groin pain versus lateral hip pain. And that can be a useful differentiator between hip osteoarthritis and gluteal tendinopathy. Um, so overall, that's a pretty good cluster of tests. Some additional ones that I'd probably add in would be like a mid-range hip abduction test. So you'd have them in a side lying position or a supine position, and we're just take them into sort of mid-range hip abduction and getting them to maximally abduct their hip. And so we can resist against that. But to go one step even further, to have some objective data, would be to use a handheld dynamometer. So we can then see differences side to side, but also can be useful to monitor progress over time. So I think that's a useful addition. So to put that all together, we've got our functional performance tests, we've got our palpation, we've got our single leg stance, and then we've got our other special tests, which include the AD and the AD-R. We've got the fader and the fader-R, as well as the Faber test.
Lots of acronyms there for you. That's perfect. So I like that you started with some functional assessments, some functional testing there, in addition, obviously, to palpation, because when we're talking tendons, we can't really kind of exclude the idea of using movement and exercise as part of the management plan. It's going to be the primary part of the management plan. So let's go into that now. We've identified that somebody's got GTPS, we've got a gluteal tendinopathy. What do we do to help that person's tendon?
Yeah, perfect. So obviously understanding what their current exercise history looks like. So what are they actually doing at the moment? And so if they're doing high volumes of exercise, we've got to sort of look at pulling that apart and seeing what may be some contributors to the increased level of sensitivity. But when we look at gluteal tendinopathy, or any tendinopathy for that matter, it's usually not the best approach to have them completely rest. So we need to modify load, but not complete rest. Okay, so I think with a management strategy, we've really got to look at what they're currently doing. If they're doing minimal to nothing versus someone who's one of those overuse-based tendinopathies. So we can't really sort of say this is where you start for everyone, because for someone who is at that lower end, more sedentary, there may be more lifestyle influences, various other factors that are contributing to the pathology here, versus someone at the other end of that scale. So assessing what they actually can do at this stage, what's their current capacity, and then creating an exercise program based on that. I think an important thing is also, depending on the person, what they enjoy doing, what they actually have time to do, what equipment they have available to use. All of these factors are important, because if we go and prescribe someone with, 5, 6, 7 exercises, and they don't enjoy doing it, they don't have the equipment, they don't have the time available to commit to that, then it's more than likely going to be ineffective. And that can lead to sort of the progression of symptoms and poorer outcomes in the long term. So I think to start out with, when we look at load management, we've got to modify those variables. Are they doing too much? Are they doing high amounts of plyometrics, so high amounts of stretch shortening cycles? Are they doing box jumps, running, skipping, all of these things that may be quite provocative? Or are they doing a lot of sitting, not doing a whole lot of anything, but they're in a compressive load for an extended period of time? So it's a difficult one to sort of start out. We've got to go through a bit of an assessment and see what they actually can do, because otherwise, if we don't hit that mark of where their baseline capacity is and we're shooting too low, that can again sort of delay outcomes. Because we know when strengthening tendons, it doesn't really matter what type of load that we put through it. So if it's a concentric, if it's eccentric, if it's isotonic, it really matters more about the intensity. So the amount of stimulus applied. So it's got to be a fairly heavy intensity to stimulate adaptive responses to the tendon. And I think that's where a lot of people tend to go wrong, is they overprescribe the volume of exercises. So high repetitions at a lower weight. Whereas I think when we're looking at increasing capacity through a tendon and increasing strength, and these adaptive responses, a higher amount of load, but at a far lower volume, so lower rep range. I think that's a good place to start. And so for some people, it might be starting with floor-based exercise. But moving away from floor-based exercise is important. So as soon as we possibly can, get them away from floor-based exercises to higher loads, such as more functional-based exercises in a standing position. I think that's important. Too often we see a lot of bridges, supine bridges, clams, hip abduction, all of this sort of stuff on the floor that's prescribed, along with stretching that's often not very helpful at all. So, yeah, I guess to sort of sum that up, I mean, assess what they can do, and then work from there. Ideally, it should be a slow progression, but see how they respond. And if we can educate them, let's say that we prescribe a patient to start with just some sit to stands, and it could be some like a deadlift, for example, and we prescribe them with 3 sets of 5 reps at a pretty heavy intensity. This would again depend on the sensitivity and the irritability of that person. 2 times a week. And so we're applying some stimulus that's pretty heavy. We don't need to do it every day. And that's often the problem with these overuse tendinopathies, is that people go, all right, you've got an overuse tendinopathy. Here's 5 exercises. I want you to work 4 sets of 10 every day, twice a day. And it's like, well, hang on a minute. That doesn't make sense. So let's reduce that volume. Let's find an exercise that they enjoy, that's comfortable. They can get to 5 reps at a pretty heavy load. And they've got time to do that at least twice a week. I think that's a good place to start.
I'm going to dive back to a comment that you made in this last bit, which was about it doesn't matter what type of contraction you do, isotonic, isometric, providing the load's heavy. Do you think there's a caveat to that based on the sensitivity or state that the tendinopathy is in? So if they've got a very reactive tendinopathy versus maybe something more chronic?
Yeah, for sure. I mean, like, there is some evidence that will suggest that isometrics can be useful to decrease pain in the short term. I mean, if it is too painful for them to do a partial range of movement or a full range of movement exercise under higher loads, then yeah, an isometric is going to be a stimulus that we can apply some neurological adaptations to that area, without potentially stirring them up further. So isometrics certainly can be used in the short term. I don't think they should be anything that the patient sticks with in the long term. So I'm talking short term, 10 days, 14 days max, and then ideally moving on from there. Because if it's not reducing their pain in the short term, what have we missed? What else could we modify as far as those contributing factors? Because yeah, when we think about just walking, we can't walk with an isometric contraction. It's a good way to put load through an area, isometrics, but we've got to get them back to sort of more those functional movements and isotonics.
Yeah, and that really highlights the importance of progression, doesn't it? If we're not progressing, we're plateauing, and if we plateau long enough, we start to go down the hill rather than up. So yeah, that makes sense. And also ties back into the importance of that functional assessment to really give you an idea about where is the patient in this moment, so that I can work with them where they are rather than where I'd ideally have them to be.
Yeah,
and move forward from there.
That's right. And I think don't be afraid to sort of apply that higher load. I think so many people get afraid to prescribe barbell-based exercises for people. I mean, I love my strength and conditioning stuff. I don't always prescribe barbell exercises, but I do think that that's a great way to apply a higher intensity to people, and they can do it, and they often enjoy it as well. When we think about that, like getting that load right at the start, and not just getting stuck with staying on these lower level exercises, because that's where they can sort of say, oh, well, I've tried this and exercise, it didn't really work for me. So in that, if we prescribe those higher intensities and higher loads, obviously if someone's really sensitized, then do less. But we can educate them about this as well. So let's say, for example, we've got someone doing even just a single leg box squat. So sit to stand, single leg, unloaded, and they can sort of get to 5, but no more. Great. Let's start you with that. But if your baseline pain's at a 4 at the moment, and it's no worse the following day, great. Let's see if we can increase the total volume. So it could be that we go to 2 sets of 5 instead of 1 set of 5. All right, so we don't necessarily need to increase the rep range. We could increase the amount of sets performed. And then the same goes, as long as it's no worse the following day. 24 to 36 hours is typically where those tendons will speak to us. And that's where those changes in the tendon matrix can occur, water binding and all the stuff that we spoke about before. So if that pain is no worse than the baseline level of pain, that can be a bit of all right, let's move forward slowly. All right. But if it is much worse, if they say, well, the following day, getting out of bed, it was sort of up around a 6 or a 7. Okay, don't panic. That was a bit too much. Let's wind it back a little bit. All right. And so we can educate our patients on how to do this. That can be so important, because rather than them having to wait 2 weeks to get back in to see you, or whenever your next consultation is, they know that immediately that following day what their exercise should look like, and that they don't need to get to those 4 sets of 5 or 6 that you've prescribed them. And so knowing that, I mean, we think about that progression over several weeks. It could be that, all right, well, we go to 3 sets of 5. And when we're at 3 sets of 5, all right, well, do we need to go an extra set, or should we just start to add load here? Because their capacity is increasing, their endurance is increasing. Let's get them to hold on to a dumbbell. So let's start with a 5 or 6 kilo dumbbell. Can they get through that? Can they perform that to the desired rep range without the onset of increase in symptoms the following day? Tick the box. Great, move on. Let's do that in the second and third set, and so on. And so if they're getting to that point where, great, I can get through those 3 sets of 5 reps with no with a 5 or 6 kilo weight, and I feel great the next day. All right, let's make that exercise more challenging. So it's not about just increasing. Great, let's get you doing more sets and more reps. Let's make the exercise harder. Let's load you up that little bit more. And that's got to be specific to the person as well, because if their goal, their end goal is to get back to running, well, we've got to start to integrate some deceleration work. Can they sort of land and stabilize? Can they then land, stabilize, and then spring off again? So that's that sort of energy storage, and release. And can they do this repetitively? All right. So that's sort of getting the springiness back to the tendon, and restoring those the functional capacity of that tendon. Because yeah, strength exercise alone wouldn't necessarily be adequate for a runner or someone who's wanting to get back to CrossFit, doing box jumps and so on. Strength is a great place to start, and I think it should be consistent throughout their rehab journey, and also just as far as a prehab thing as well. But then that's where the periodization comes into it. We've got to start to integrate some deceleration work, some energy storage and release, and sort of those repeated energy storage and release contractions.
Yeah, right. And that's the key thing, isn't it, with exercise prescription? It's specificity to the structure, but it's also specificity to the function. And if you're dealing with a runner versus a gymnast versus someone who's just got sore hips from sitting at a desk all day, like the type of exercise progression needs to be make sense from a physiological point of view, but also make sense for what's their end goal functional capacity that we're trying to develop. And so, like, a perfect example of the runner, like I dealt with a lot of runners in my career, and if all I gave them was the standard protocol that you get from Cook and Purdom, back in the day, they'll only be able to withstand tendon pain or tendon load in standing, but go to run again, and they've got a problem. So we need to add in some dynamic movements, some recoil type stretch recoil movements, and building back that elastin component of the tendon so that it can actually do those things that of the those demands of the activity.
Yeah, exactly. And even from just a patient's satisfaction point of view and their enjoyment, it's when people present with pain, typically these sort of tendinopathies and classic in the lateral hip, where it's not usually that they're seeing you within the first month or so of these symptoms. It's usually several months, in fact, years on. They'll say, "Oh, I've had this for a couple of years now." And you sort of ask, "Well, what is it that made you come and see me today?" Well, it's often when it's starting to affect their life. It's affecting their participation in sport, exercise, social activities, work, whatever that may be. It's starting to stop them from doing something. And if you take someone who enjoys doing something, but pain is limiting them from doing that, we've got to try to integrate that back into the plan as soon as possible. And not saying that, no, you can't run, you'll never run again. Let's just wind that back for now. But we will get back to that. We will start to integrate that in because that's what you enjoy doing. I don't want you to ever stop running completely. Let's just reduce the volume at the moment. And same goes for CrossFit, anything for that matter, stretching, yoga, whatever that may be. There can be certain things that provoke and increase sensitivity of that area. But at the same time, it's not goodbye forever. It's just see you later for now. Let's reduce
Yeah,
that for
right.
now.
Gotcha. Okay, so but you would know this too. Like I talk to a lot of clinicians. You talk to a lot of clinicians in our travels and teaching, and invariably people go, "I've got such tendon problem presenting in my clinic, whatever it is, whether it's hips, knees, elbows, shoulder, whatever." The answer or the solution is invariably exercise load-based management. And when you present that to a clinician who particularly is a manual therapist, they'll often look at you and go, "Oh, okay, well, that sounds a little bit complicated, but in the meantime, what can I do with my hands or my tools to help this person?" And the evidence all points to exercise and load management. But do you think that there's a place for manual therapy still in the management of tendinopathies?
Yeah, such a good question. And it's sort of that's the thing. The hard answer is, well, exercise, if it's an exercise or it's a load-based presentation, let's call it that, because it could be underload, it could be overload. Well, then the intervention is most likely going to be load-based. And so if you've got a pathological tendon, you can't necessarily rub that tendon better, laser it better, shockwave it better, whatever that may be.
What?
We've got
Hang on a second. Wait, hang on. You can't. You just,
so
I think we're upsetting a lot of people here, but be careful.
yeah, I mean, and because and that's the importance of understanding the pathophysiology of what's actually going on here at the level of the tendon and also the complexity of the pain experience. And so can we use manual therapy to modulate pain? Absolutely. But we know that manual therapy doesn't change structure. Okay, so we can certainly use manual therapy as a part of that overall integration of modalities to reduce someone's pain so that we can then progress them along their rehab journey or getting them back to exercise and their meaningful activities. But the thing is that the manual therapy, poking, prodding, rubbing, lasering, needling, all of that stuff won't necessarily change the structure of the tendon, but it can be a great modulator of pain. So I'm certainly all for the integration of manual therapy in these presentations, but we've got to look at what those contributors are that are contributing to their symptoms, how we can modulate their pain to then start to build the capacity of that tendon and get them back to those meaningful activities once again. So it certainly all forms a part of that plan together.
Yeah, fantastic. And as always, manual therapy is essentially an improver of compliance when it comes to patient compliance. Like we're going to get better compliance when they have less pain, and manual therapy is a great way to achieve that. And it creates a window of opportunity for the person to take a step forward rather than be being stationary or stepping back due to apprehension or fear or avoidance type behaviors. So yeah, I'm with you. Manual therapy has its place, but it'll only get you so far, right? There has to be something more. And I think you hit the nail on the head when you said we've got a load-based problem. There needs to be a load-based solution, not a passive intervention solution. That can only be the starting point.
Yeah, and to give you an example, I mean, I use a lot of dry needling, and particularly with these lateral hip pain presentations, where I might use it more as a way to modulate pain for one, but as more of a facilitatory technique. So we can use it sort of a fast in, fast out approach, and then immediately go into exercise. So use that as a way to modulate pain where we've got some segmental inhibition, some endogenous opioid changes. We may have some changes at the level of the motor unit as well, increase excitation, and then get them straight into an exercise where you'll often see, this is useful to do, and we cover this in our hip and pelvis dry needling course, where we use handheld dynamometry pre and post needling immediately. And so you'll see significant changes in the values on the handheld dynamometer, increases in strength. The patient will go, wow, that felt a lot easier and it felt a lot stronger. Great. Let's use that window to now see if we can get you doing some load-based exercise that now we're using that to increase capacity of the tendon. Because I know certainly that the needle wasn't necessarily changing any pathology around the tendon and the matrix there, but using it as a way to modulate pain and potentially facilitate some of those motor units to then immediately move into exercise. And as you said, can improve that compliance. So we can then accelerate them along that exercise and rehab journey a little bit faster.
Okay, let's finish off with this then. So we talked a lot about the right things to do when people have tendinopathies or lateral hip pain. Talk to us about some of the things that we shouldn't do. I'm guessing corticosteroids is probably going to be in there. There's a bunch of things that people have done. You mentioned stretching earlier. What should we be avoiding when it comes to GTPS?
Yeah, so we go back to those again mechanisms of what can sort of cause or contribute to lateral hip pain. And the classic one is sort of, the patient will often have a perception that it's tight because pain means tight, or that may be their best descriptor for pain. And so patients will often do this, and clinicians will often prescribe it as well, as we'll stretch out your ITB because that must be tight. And what do we know about hip adduction? Increased compressive force. And the same goes with like a glute stretch, such as a pigeon stretch. That's very much the same as our pain provocation test. Clam exercises are overprescribed, and I don't think they're a very valuable exercise. They can increase compressive load, and they're just not, in my opinion, a very good exercise to apply the appropriate stimulus. So yeah, stretching, like even foam rolling, like it depends, if we're on our side and rolling through that ITB, and does that increase the compressive load over the hip? I mean, it can be a way to modulate symptoms. I'm okay with that. But just be mindful of the compressive load over that lateral hip. Other things is just educating people about certain positions that increase compressive load, such as standing, hanging out on one hip, crossing the midline when they walk, laying on their side. So if they're laying on their side and that's uncomfortable, well, lay on the other side, but bolster a pillow between your knees, or lay on your back in a supine position with a pillow underneath your knees, or don't cross your ankles over when you're in a supine position. For now, we can get you back to those positions, but for now, while it's irritable and sensitized, let's decrease that. And so, yeah, we sort of mentioned before corticosteroid injections. We know from the literature that it has a short-term benefit, so it can be better than conservative management at 3 months, but it's often no different at 12 months. It can also lead to increased follow-up corticosteroid injections, increased visits to primary healthcare providers, overall increase in cost, but it can negatively affect tendon health. And so when we think about the influence of a corticosteroid injection and that passive approach, and the patient may view that as sort of a quick fix, Well, I mean, unfortunately, it's not very good for the tendon's health, and therefore, in the longer term, when we're looking at exercise, it's more than likely going to be worse off than conservative management. So, yeah, with that being said, I think it's important to understand that these can take quite a long time. It's not usually solved in 2 weeks or 4 weeks. It can be a minimum of 12 weeks. And often in more severe cases, it can be 12 months, 24 months. But in
And when
that
you're talking
time,
solution, so
so
when you're talking solution there, that's total resolution. People could still make a partial return to activity and do things during that time, right? It's not just you have to stop doing your sport, your activity for that long.
yeah, exactly. And that's the thing. We're getting them back to those meaningful activities. And it's probably also important to set up expectations of what you think or what's a reasonable level of pain for you. Because some people, it's not necessarily about the pain. It's just, I want to be able to get my life back. And so we shouldn't always have the expectation or the focus on pain of getting that to a zero. It might be that, look, I can manage a 4 out of 10. I'm fine with that, but I want to be able to run. I want to be able to sort of squat down and play with my kids. I want to be able to get through a full day's work without, being in discomfort, or I want to be able to have a full night's sleep. So setting up those things, those expectations, I think are important. But understanding that this will be a journey. It will take some time. It will require some input from your part, particularly exercise and management, and reducing those provocative factors. Um, so it'll be a little bit of teamwork here. And you as the clinician, you're there to modulate pain and educate them and progress them. I think that's the important part.
Perfect. Bo, that's a really good insight. I think that will answer a lot of questions for often a very confusing and frustrating presentation. I've seen plenty of lateral hip pain in my time and had some really good successes and some really severe frustrations with patients. I do the same thing on two people that present the same way, and one gets better and the other one doesn't. And often I think it's some of those key insights and small modifiable factors that you've highlighted that could make the biggest difference for people. So it doesn't have to be complex, but we have to understand the pathology. I think that's the key thing.
Yeah, exactly.
Yeah, perfect. All right. Thanks everyone for listening. I'm sure you got plenty of gold and gems out of that one. Bo, we'll wrap it up and see you all again soon.
Thank you.